I think we're really excited to hear from you today, Megan. You and I met 4 years ago, I think, when we were busy recruiting you to Fred Hutch. And I at least have been really excited to see how your research has come along. In our institution, my memory is one of the reasons why you came is because you really wanted to be in a place that had a larger patient opportunity for you. And I hope we've really been able to deliver on that. It looks like today your presentation is going to be on something that is very patient focused, which has to do with thinking about cancer nutrition in our patients. So welcome, Megan. Thank you so much.
Thank you so much, Nancy, for that introduction. I'm really happy and delighted to be here reporting out results from a small pilot trial that we did working with the breast cancer population. I know many of you, but for those of you who don't know me or are less familiar with my work, I'm an associate professor in the clinical research division, and much of my work focuses on health communication and decision making with the goal being around patients being informed decision makers. So much of that work is in the advanced cancer patient population, but was really excited to do this project, which focuses a little bit more on the earlier stages of breast cancer patients and thinking specifically about their access to information around nutrition as it pertains to their cancer. So this was a really fun project that actually emerged out of Heather Greenlee beginning to put together the early stages of ideas around a PO1 application. And as we sort of brainstormed that, we started to narrow in on how we could begin thinking about addressing some of the nutrition misinformation that lives online that patients are often accessing, but often wanting, to have accurate health information and nutrition information specifically for their cancers. And so from there began a collaboration with the UW team, the Center for Informed Public, that do a lot of work in the misinformation space. And they had an interest in doing this in the health space, but hadn't yet done that. So thus a fun collaboration was born. And these are the results of this project that I'll be talking about today. So this is the team here on the slide. Chris Coward, who's at UW. Lynn Simons, our wonderful point of contact in the breast oncology group. Jin Ha Lee, Julie Kentz, and Rachel Moran are all at UW. And then my team, without whom the work could not have been possible, Claudia, Sarah, Maya, and Trevor. So let me jump in, make sure my slides are advancing. Okay, so today I'm going to do a little bit of background about the sort of scientific premise and reasoning for this project, the study design and aims, and then of course the results and conclusions of the project. So the background was that, obviously misinformation has continued to be a challenge for a number of years, but I think the COVID pandemic brought to the forefront both just how prevalent that misinformation is and the dangers of health misinformation can lead to multiple serious health consequences. And so we were really curious about how this looks specifically in the space of cancer. So cancer misinformation has become increasingly prevalent. And part of that is due to just a burgeoning of online spaces where these things live, whether that's through different boards, posts, social media. Rachel, who's worked on this project pretty heavily and been in the trenches at University of Washington, has sort of gone into many of these spaces to see what are the conversations, and there's a real breadth of for people to gain access to both accurate and inaccurate health information. Within the nutrition space specifically, nutrition misinformation is actually fairly widespread. There's been very limited research on it, but the research that has been done has shown that there's a lot of health claims to say that certain products will prevent disease when that is untrue, treat it or cure it. And so, and then phrases such as anti-cancer, cancer fighting are commonly used for recipes. In this study, they reported on recipes used on the website Pinterest. But we found in our own work, of course, these are often linked with supplements, which are not regulated in the same way that drugs are. And so there's a lot of misinformation that lives specifically online that affect our cancer patients. Unfortunately, education alone is rarely effective for combating the misinformation. And part of that is because it's a rapidly changing environment. It can look very different. And so we are really interested in what it would look like to teach patients the actual skills to sort of find accurate health information on their own. And so that's what this project sort of built on. So it built on some prior stages of research looking at, taking a gamified approach to building resilience to health misinformation. So can we use a game-based intervention to sort of teach patients how to be on alert and recognize misinformation when they see it, as well as how to actually find the accurate sources of information, namely their medical team. And so we felt that this was a promising new target for how to combat misinformation that was grounded in prior work that my colleagues at UW have done in other misinformation spaces where they created an escape room-based online game. They've done it both in person and online, and found that they could actually begin to teach people skills to start recognizing misinformation online. And so we took that sort of model and tailored it specifically to the breast cancer patient population. The goal of the study I want to talk about today specifically is to pilot test an escape room intervention that was designed to reduce breast cancer patients' vulnerability to believing cancer nutrition misinformation. So the study design was that we wanted to teach participants to really discern between accurate information and then possible misinformation. So they played this online escape room game, and the game content was really focused on some common tactics that are used to spread misinformation. Things like cherry picking study data, using questionable expert influencers, overgeneralization, misleading headlines, strong play to emotions. And this game was developed based on some feedback we got in early stages of this project and research, where we interviewed patients as well as providers and those in nutrition working with this patient population to really tailor the game for these patients. Our intervention follows a fictional company that we call Zen Fusion Wellness. Sell the game players a nutritional product to make profits. So players work in groups of 3 to 5, which is a real nice feature that players actually really loved, was sort of the group-based dynamics. And they work together to solve puzzles while they're learning key themes, such as the need to talk to their doctors, look for scientific studies and FDA approvals, be aware of fads, trends, miracle cures, clickbait ads, and anecdotal evidence. And all of these components were sort of blended with pulling from prior research, as well as researching ourselves kind of what lives in these online spaces. So all individuals who consented and enrolled in this study first filled out what we called, the pregame or the baseline survey after they consented. They then participated in a misinformation escape room game with, again, those 3 to 5 players. And then afterwards, as part of the game session, they did a semi-structured qualitative debrief interview. And that interview was both designed to capture some qualitative data around their experiences with the game, lessons learned, and feedback, as well as to be a little bit of a teach back to see what players learned and how they might apply this in their own lives as they're looking at nutrition information online. Then they received a post-game survey within a week's time that was completed on their own, much like the baseline survey. So that was sort of the study flow. We did this with stage 1 through 3 breast cancer patients that were all currently in active treatment. Our goal was 40 participants, although as you'll see, we actually ended up enrolling 43 because to get enough players in the game, we had to sort of over-recruit a little bit, but we're able to do that. So the first aim of this project was to really examine the feasibility, acceptability, and usability of the escape room game intervention among breast cancer patients in active treatment. So our cutoffs were for feasibility that at least 50% or more of those who are screened and eligible chose to enroll in the study. For acceptability, we were looking to see that 70% or greater of patients would rate the intervention as satisfactory, and that would be a score of 7 or higher on a 10-point Likert scale, and I'll report on these data a little more specifically. But it looked at how satisfied they were with the intervention, as well as whether they would recommend the game to others. And then for usability, the cutoff was having greater than or equal to 70% of patients who sort of met the pre-normed criteria for usability. And we used the system usability score, where the cutoff point there that's normed for sort of acceptable usability would be 68 or higher. Then we had an exploratory aim 2, where we wanted to begin to look at preliminary efficacy of the intervention on certain outcomes to see if there was an increase in a trend in the right direction pre-post. So looking at increasing awareness about the types of online misinformation, their concern about misinformation, confidence in their ability to identify it, as well as if we could decrease cancer nutrition misinformation beliefs. So these are the sort of demographics of the study, the population that we had, or the sample that we had. So the average age was 51.8. This is out of 43 patients. Predominantly white Caucasian with some Asian, multiracial, Hispanic, and Latino, which is fairly reflective of our patient population. You can see their education and household income also fairly reflective. These were all patients recruited from the South Lake Union campus. And I'll talk a little bit more in conclusions, have goals to kind of begin expanding recruitment to a more diverse population. So the results of AIM-1, when we look at the acceptability, how satisfied were you with the escape room game, we found that we sort of just missed the cut point of 7. So on a scale of 1 to 10, the average was 6.8. And then how likely are you to recommend the game to someone else is on a scale of 1 to 5, where a mean of 4 would be the cut point there. We're a little below that as well. And I'll talk a little bit about these metrics around acceptability, feasibility, and usability. For usability, we again fell a little bit short of the cut point for usability. So we want to see a average of 68 or higher. And so our mean here was 59. And so these are data from all the patients who were able to complete their post-game interview, which was all patients who participated in the escape room game. The exploratory aims, when we begin to look at some of the outcomes around health information, first we asked them where were they going to what resources were they using to find their nutrition information on. And so we find a vast majority through self-care, health, and wellness books. And obviously the largest category here is internet search. So much to our anticipated results, we find that internet is the most common source of information patients are going to find nutrition information. When we asked them after playing the escape room game and participating in the debrief game, the degree to which they agreed in each of the following, we see that they are less, we call this kind of the third person effect, where they feel less likely that they would believe misinformation or share it, and more concerned about society and others as well. So part of this could be because individuals feel that they are not part of sort of the normed average, but it also could be an indicator that the game is giving them more confidence in their ability to recognize that misinformation. We did assess cancer nutrition information beliefs. So this was a scale that asked the degree to which they thought certain statements were true, like sugar feeds cancer. And we came up with a list of statements that were based on prior research in what are commonly held nutrition information beliefs, or I guess misinformation beliefs. We did see a slight increase in them having accurate beliefs, although significant, sort of to be determined if that's a clinically meaningful and relevant shift in outcomes, but we did see improvement in them having nutrition information, so accurate beliefs in this case. When we look at trust and information seeking, this was really encouraging to see. I think one of our primary goals as a team when we sat down to think, okay, what are the outcomes we really hope to target? The 2 outcomes we were most interested in was that people would be equipped to detect misinformation online, and perhaps even more importantly, that they would really be encouraged to check in with their doctors and their medical teams for accurate information. So we did see some improvements from things like trusting health information they get from their doctors, reduced trust in health information they read on the internet, not as much of a shift, but a little bit as newspaper as well, and more likely to trust information I get from the internet than they are from friends. We saw a reduction in that. More likely to trust information they get in the internet from their doctor, also saw a reduction in that. So we saw trends in the right direction, where patients were reporting much more likelihood to trust their doctors, less likely to trust internet. And it's not that we want patients to feel like no accurate health information lives online, but more so to recognize that they can always trust their doctors and medical teams to give them accurate information, and or even run by health information that they're seeing online to improve those sources of ensuring accurate access to information. When we look at how much they enjoyed the game, we were curious to see this because, as you saw, one of the challenges is that we had really excellent feasibility. So a lot of people enrolled in the study all finished the sessions and assessments, but we saw lower than desired levels for the acceptability and the usability. And this gives us a little bit of more insight into the levels of game enjoyment. So this was asking them to rate their experiences of the game from not at all or extremely. So higher scores would be, for a positive item, a better score. So things about feeling content, skillful, how interested they were in the game story, if they found that it was fun. And so what we see here is kind of a little bit in the middle here, indicating that there could be a little bit more immersion in the game for players, and perhaps feeling a little bit more need to engage in skill mastery or maybe problem solving the puzzles being a little more challenging. So I'll talk a little bit in the conclusion about our thoughts as a team around some of these results. We also assessed essentially what we call healthy skepticism. This is a scale that asks people to look at a social media post and then sort of determine the degree to which they agree or disagree with certain statements. So whether it was emotionally manipulative or overgeneralized. And these were posts that were designed to be more misinformation driven. And so we don't see a lot of shifts pre and post here, which could be an indicator that patients were already fairly aware of certain tactics or might be more able to recognize these things even prior. And so sort of see similar means across the pre and post game scores there. To misinformation, the sort of general perceived difficulty did reduce a little bit, although not significantly. We did also see changes in what we call the third person effect, which is the tendency to be more confident that you compared to others are more able to identify misinformation. And again, obviously, we need to do a little bit more research to determine if that's due to patients actually being more equipped to detect misinformation, or if we're unintentionally creating sort of a placebo effect or a false inoculation where they now feel really confident and so they're less likely to recognize it online. And so that's something we're thinking about in future iterations of research at looking at more thoroughly. We also looked at their confidence and comfort in sharing information with a medical professional. This did increase slightly, as well as their awareness of misinformation. So again, these are small shifts, and we would hope to see greater shifts in scores, but we are trending in the right direction for the outcomes that we're hoping to target if we carry this forward to a larger trial. So kind of in summary, I think really encouraging was the high feasibility that we saw of patients interested in enrolling in the game. 97.8% of all consented participants who were screened eligible chose to enroll in the study, and 95.6% of all enrolled patients completed their post-game survey, as well as participated in the game. So we saw really high rates of engagement. I think where we're looking to make improvements in future iterations is around the acceptability and usability of the tool for patients. We got some excellent feedback from the qualitative interviews that we did in debriefs, which indicate that patients maybe could have felt more challenged, or there might be components of the game that would make it a lot more value added. So for instance, many patients mentioned that they would love to have a nutrition expert either be the one giving the debrief. We've talked with Dr. Simons about some ideas around this where we could embed videos where after each puzzle or game, somebody, a nutritionist, could sort of pop up on the screen, debriefing the puzzle and game and applying it to real world scenarios or sort of what they could be thinking about as patients. I think patients are really eager to know what were the accurate nutrition beliefs, so that they felt a little more equipped and ready with true information, not just how to spot misinformation, but what are the true facts around nutrition that they should be aware of. So our next steps as a team, is taking the results of the pilot study and especially some of that feedback from patients' experiences with the game, to think about a secondary iteration of the game to better tailor and target it. Because of where we recruited, this was a really highly educated, pretty well-informed patient group. And so we want to be thinking about how to make the game engaging and challenging enough, and also to feel like it's value added for the information that they're learning. But we were really encouraged to see that it was encouraging more direct reach out and sort of conversations with their medical teams, with their doctors around nutrition information, and a really strong interest among patients in learning more about nutrition. So I want to say thank you to the team. Rachel and Maya did an amazing job of coordinating a lot of escape room games. It wasn't easy always to find where 3 to 5 patients could all meet together and play, but we found that the group-based aspect was really a strong feature for patients. In fact, we actually had to integrate midway through the study how patients could sort of opt in to sharing information, because patients at the end of the game were like, I want your contact information, or how to connect with patients. So we felt like the sort of group-based component was really well liked among most patients. Obviously, Dr. Simons for her incredible work in feedback on the project, as well as coordinating with clinic and recruitment. And then special shout outs to Dr. Young, Speck, Hunter, and to Amy Bruce Kern, who were also really instrumental in giving us some feedback on clinical integration and recruitment efforts, without whom the project couldn't be done. So I'll pause there for questions, and want to thank you all for your time.
Megan, hey, thank you so much for presenting this. Great, excellent work. I guess I wonder, looking at the demographics of the patients who participated here, if some of the findings aren't explained. It looked like it had a pretty highly educated, I mean, I think lots of college grads and post grads. I'm wondering if the bar was a little bit high for usability, like I think you identified. Are there any tweaks that can be made to the game itself, or do you want to leave it as it is and just try it in a more diverse population? I guess I'm trying to think. There's a couple different ways you could probably go with this if you were looking to develop the 2.0 version.
Yeah, no, that's a great question. We actually, the sample's small enough that you have to interpret these data with caution, but we did look at some of these outcomes around the usability and acceptability scores by educational breakdown. And it does seem to be supporting exactly what you're saying, that patients who had a much higher level of education also had lower ratings of acceptability and usability. And so kind of we're thinking about this in two ways. So one is we do want to find a way to make the game a little bit more engaging and value added. So I think the baseline levels of knowledge that patients were entering in, as well as perhaps their expectations of the games, may have been a little bit misaligned. And so we do want to sort of develop a version that is, maybe the games are a little bit more challenging, or there's a little bit more opportunity for patients to feel like they're actually having to work a little bit more at solving the puzzle, because a lot of game theory shows that you have to really hit the sweet spot of tension, where it's hard enough that players are engaged, but not so challenging that they give up and don't feel like it's an achievable puzzle. The other thing we want to do, regardless of educational level, though, is somehow integrate nutrition experts into the game, whether that's like through, like Dr. Simons had a great idea that we could have video pop-ups after each puzzle. I think realistically, it's going to be pretty challenging to make a nutritionist like the person debriefing every game. But we want to be thinking about, and I welcome other people's thoughts too here, of how to really integrate that, because that is something that patients very explicitly and expressly wanted, was like, I want to talk to the expert or hear from the expert and know, after each game, what are the takeaways? Like, how would this really apply for myself and my care and my nutrition as a patient? So those are a couple different ways we're thinking about making modifications.
So Megan, I know you talked about it, but I wonder if you could amplify a little more kind of the future directions and who would fund this kind of thing and those kind of things.
Yeah, great question. So we are really, in this next phase of research, we really are trying to think about future dissemination of this game, and how we can make it feasibly integrated into patients, patients having access to it. So in the short term, we are currently trying to seek funding to test a second iteration of the game where we do make these modifications. But within that, we want to embed thoughtfully, how can we make this achievable to kind of roll out to patients. So we would like to begin looking at, an actual person debriefing versus, are there ways to make the debrief patient guided, to where, you could see this in maybe patient online support groups or spaces where patients are already gathering, and they could have access, because the game itself, anyone could play, and there can be they can be equipped to solve the puzzles or have the debriefs on their own. So we are trying to think thoughtfully around how can we do this? What's the value added of a real person running the game versus not? And are there sort of intermediary versions of this that we could offer and roll out to patients?
Thanks.
Thanks so much, Megan. That was really interesting. And it's sort of following up on Nancy's question is, are do many of these patients have access to a dietitian or nutritionist as part of their care already? I mean, because I could see a combination of, the sort of more generic debrief presented as videos in a general sense of, these are the problems, this is the solution approach, but then to then encourage them to interact with their nutrition caregiver on their specific components. I don't know how feasible that would be.
That's a really good point. I think with this population, they had a much higher level of access to a nutritionist than, if we were to maybe look in other populations. That being said, not all patients had interacted with a nutritionist, but you're bringing up a point that I think is something we should really think about embedding for, again, that value added for patients, which is like, maybe at the end of it, a checklist of like, these are the 5 questions you could ask your healthcare team or something, depending on patients are going to have varying levels of access. But I think you're absolutely right that patients are craving, like, how can I actually loop in somebody to talk to my provider, whether that's a nutritionist or if patients don't have access to a nutritionist, if we think about rolling this out more broadly, how can they talk to their oncologist or a nurse or somebody else on the team? So I think that's a really good suggestion to think about, thoughtfully how we can equip patients to have those conversations.
Yeah, great ideas.
Well, Megan, it's a great presentation. And Megan presented this to the PO1 working group that we have that we're trying to get together. And so we're in discussion about what work would need to happen to be able to get this ready to be a project that would be ready to submit as part of the PO1. And the breast group is aware of the Cook and Move for Your Life study that was funded through Nancy's BCRF grant. And we're also hoping to gather some additional preliminary data from 2 studies that we're hoping to open in the breast group within the next couple of months. One is an online self-paced culinary education program, and another one is providing patients who are undergoing chemotherapy information about how to use nutrition to manage side effects during treatment. And so the PO1 concept that Megan and I have been talking about would be thinking about how to use electronic education or information dissemination to patients at different periods during their treatment or their diagnosis and treatment trajectory. But we're just trying to gather strong enough preliminary data so that we could actually put in a feasible PO1 to get funded. So stay tuned. But Megan, can you talk a little bit? One of the things that we had spoken about with the team at UW is whether or not to be, how directive to be in the game with telling patients information as opposed to just saying, this is what misinformation is and how you look for misinformation, as opposed to this is what our clinical recommendations are for you using nutrition in your lifestyle going forward. Can you talk?
Yeah.
There's a little tension there between what the different groups were comfortable doing.
Yeah, and I do think that one lesson learned in this is we probably shouldn't. So traditionally on the misinformation side of things, the goal is to be fairly non-directive. So you're equipping users or players to sort of learn to capture these things on their own without actually saying like, this is the right information, this is the wrong. But we are dealing in a space where there are some accurate and known facts and some commonly known misinformation beliefs that patients really want to know. Like if you could just give them a list of like, these are the top 10 most commonly, said things, I think patients would have really found value in that. I also think that in prior iterations of this game that UW did, there was more misinformation tactics that I think surprised people, or where people felt like real learnings were happening in terms of like showing a deep fake video and being like, wow, it actually looks a lot realer than I realized. But in this context, some of the tools and tactics may have felt a little more obvious to patients, especially the population that we're working with. So I think it's going to be a blended model of making the game a little more engaging, like targeting things that they might be less aware of. But also I think we are going to have to move in the direction of a little more explicit guidance, because patients, that's something that kept coming up over and over again, is like, just tell me, just tell me what it is. And I think that is a big question here is, I think the goal of the game is that it really can teach skill sets rather than just facts. And we know the education literature shows that anytime you can do that behaviorally, you're going to shift things a lot more than just like a list of facts. But we have to figure out how to make it enough value added and engaging enough that patients want to play the game or enjoy the game. Great questions.
So at this point, were they doing this in person or was it virtual?
It was all virtual through a Zoom-based session.
Okay.
So players would log into the game, and then Rachel was our amazing facilitator. She would facilitate the game, and then be available to do the debrief at the end of the call.
So cool from the standpoint of being able to disseminate further than just a, immediate area.
Right.
Great. Thanks.
And I'll say one of the things that Megan and I have talked about with the PO1 too is that we want to do it in English and in Spanish, so that we can reach a broader audience there. And we've both had different levels of success and failure in reaching those patient populations too. So we're continuing to try to figure out those ways.
Thank you, Megan.
Yeah, thank you all. Any other questions?
Thanks again, Megan. And I jumped in a little late from clinic, but is there a link for those of us? Is it possible that there's like a login that you could play the game and sort of see what it's like, and
Yeah.
that you might be willing to share? Or
Absolutely. Yeah. I know I'm happy to email that. I know Rachel, you're on the call. I don't know if you have ready access to that. If not, I can send out a follow-up email where people can try to play the game. I will
it looks
say
like she just put it in the chat. So
oh, I know. Right. Rachel's on it. So yeah, if anyone wants to check it out. And I think you will see it's a fun and cool concept, but I can also see where there are some modifications that could be made to make it, even better tailored to meet patients' needs. But yeah, you're welcome to log in, check out the game, play around with the puzzles. And let us know if you have any other feedback. We're definitely in the iteration phase. So we welcome any thoughts or feedback on how to improve it as well.
I guess I just wonder if you had a different demographic, if you sent it to a community clinic or to, I'm just making up things, Eastern Washington or somewhere where the demographics might be a little bit different, if the very same version of the game might give you different outcomes and satisfaction, just to increase your sample size a little bit, because you can imagine different types of changes depending on the feedback and the maybe the education level, or I'm not, or gaming experience or something.
Yeah. No, I mean, that's a really good suggestion that I will look into, because the group that we found in our preliminary analysis that sort of had the highest ratings of usability and acceptability were those with a high school degree, but no higher. And we also had a fair number of patients, not shocking because we're in Seattle, who are like, I'm a user experience designer, or, somebody at a very high level of knowledge. And it's not to say the game couldn't also tailor to those, but I think it might have not, if they're expecting a Google level of of design and features, I think that probably impacts the user experience as well.
Yeah, great.
And I'm just reading your note, Hannah. Awesome. I will write that name down. Because yeah, I think you're absolutely right that it might ultimately be like two versions of the game need to exist.
Yeah, I know. I think, you could look at our entire state of Washington as a catchment area, or you could look at Alaska and, even Hawaii. And, but in the WWAMI area, we've got quite a broad group. And I continue to feel like our biggest gap is the rural areas that are really underserved. And, Chris has said that the Spokane experience is pretty different than the Seattle experience. But I think, people are looking for education, and you probably are going to have multiple levels in terms of health literacy.
Absolutely.
I suppose you could sort of think about, different tiers of it. And with gaming, you work your way through the first bit and then things get harder and harder as you go along. And so you could capture everybody, but possibly that way.
Yeah, that's a great suggestion. And yeah, any of us who've played games, like if it's so easy, you're like, well, what was the point of that? If it's so hard, then you quit pretty quickly. So I think it makes sense to really think about health literacy as almost a pre-screen of what game would be the best target for individuals, because I know we have a crude measure of education by level of education, but I would imagine like health literacy and familiarity with some of these things probably is an even stronger predictor of who felt the game was useful or interesting. So yeah. Thank you all. This is really helpful. Always fun to present. And yeah, if anyone has, if you suddenly think of a idea, or if you choose to play around with the game, we absolutely welcome feedback as we're beginning to iterate. And I'll look into some of those connections. Appreciate the recommendations to think about reaching out to some of our partners across the state of Washington. All right. Well, thank you all. Have a wonderful rest of your day. And thanks for your time.